Hello everyone, in today's video we are going to discuss about normal ultrasound of pancreas and ultrasonographic findings in acute pancreatitis. This is very important diagram because in this diagram here are important vascular landmarks that are quite important for understanding pancreatic anatomy. From abdominal aorta, superior mesenteric artery arises. And another important vascular landmark is a splenic vein because this landmark is quite frequently seen in pancreatic ultrasound. Splenic vein combined with superior mesenteric vein to form portal vein. This homogeneous structure is the pancreas. This part is the head of pancreas. This is oncocyte process. Similar to that, this is head of pancreas. This is oncocyte process. This is the body of pancreas and this is tail of pancreas. Similar to that, this is the body of pancreas and here is the tail of pancreas. The most posterior structure in this diagram is this is the vertebra. Just in front of vertebra on left side, this is abdominal aorta. And just anterior to the vertebra on right side, this is inferior vena cava. So this is aorta, this is inferior vena cava. Here in this diagram, this is aorta and this is inferior vena cava. Just in front of this abdominal aorta, this vascular structure with echogenic fat surrounding it, this is superior mesenteric artery. Remember, superior mesenteric artery can be easily identified in ultrasound because of its surrounding echogenic fat. So this long structure is the splenic vein. So this is the splenic vein in this diagram. Splenic vein combined with superior mesenteric vein to form portal vein. So in that diagram, we cannot see superior mesenteric vein. However, we can see superior mesenteric artery. We can see splenic vein. This long structure is the splenic vein. And pancreas is lying just anterior to this splenic vein. So, friends, remember, abdominal aorta, anterior to that superior mesenteric artery, anterior to that splenic vein, and anterior to that pancreas. So, in this diagram, you can see this is the left lobe of liver. When you compute the echogenicity of pancreas with the liver, normally the pancreas is isoechoic or hyperechoic than that of liver. Pancreatic parenchyma is isoechoic or hyperechoic than liver parenchyma. However, there is wide variation in pancreatic echogenicity. Pancreatic size also varies widely. Generally, head is usually less than 3 cm, body is usually less than 2.5 cm, and tail is usually less than 2 cm. And pancreatic duct is usually less than 3 mm. Echogenicity of the pancreas increases with age. So here in this diagram, all of these diagram are images of the normal pancreas. But here we can see that pancreatic echogenicity is quite variable. Visualization of the pancreas may be difficult because major part of the pancreas is retroperitoneal and it is located behind the large bowel. Due to that, we use a special technique called compression scanning. We place the probe in the subxiphoid area just below the xiphoid process. So we place the probe transversely. If we slightly angle the probe downward, we can visualize pancreas. In that case, we use left lobe of the liver as an acoustic window. So here patient is lying in a supine position. Here is the xiphoid process. We should keep the probe just below the xiphoid process and we slightly angle the probe downward. Then we can see this type of structure. This homogeneous structure is the pancreas. Just keep the patient in supine position. Put your probe just below the xiphoid process. Slightly bend the probe downward and slightly scroll the probe downward. You can see pancreas. On slight compression, you displace large bowel gas and other structures that lie near the pancreas and you can actually visualize the pancreas. It is quite simple. Keep your patient in supine position. Place your probe just below the xiphoid process, slightly compress and slightly move downward. Then you can see pancreas. So,